Good morning.
How are you?
All right, and yourself?
I'm good. I hear echoing. I don't know. Is it me?
Oh, it might be me because I have my earpiece on,
Oh,
but I don't hear anything now.
okay, then I guess we good. Wait a minute. Let me see. Hold on. Uh, okay, let's talk. Let's talk.
Okay, how about now? If you still hear it, I can just take it out. Okay, how about now?
Uh-uh. As long as I mean, if I hear it on my end, it's fine. As long as the people don't hear it, we good.
Okay, yeah, I don't hear anything.
Okay, we good. We good. Ain't no telling. Lights, camera, action over here. I got monitors and stuff. You did. Who knows? Who knows? How are you?
I'm good, and yourself?
I am exhausted. I'm tired.
Really?
Yeah, I went to we had a workshop in Frisco, Texas. So I was in Frisco, Texas for a couple of days and then
Okay.
got back Thursday night.
How was the weather?
Beautiful. I needed
Really?
every bit of that 77, 80-degree weather. Every bit
Okay.
of it. It was sunny, no rain, no nothing. It was fabulous. I needed it. It was a teaser. The teaser that I needed.
It's
How are you?
36 here.
It was cold here too. Flooding, cold, all of the things. I came back like burr, full-fledged winter coat. What is happening? How was your week?
It was a week. Yeah, glad it's over.
Glad we made it.
Yeah,
We made it. I know that's right.
I I had an epiphany, but I'll save that for the meeting after the meeting this week.
Uh-oh. Uh-oh. See, there you have it, y'all. You get that extra specialty in the meeting after the meeting. All right, all right. Well, let's get started. Welcome everyone to our Saturday morning tea. Here we brew up the hottest topics in healthcare. We discuss everything: health information, news, education, certification tips, the weather, epiphanies, all of the things, as well as entrepreneurship and really the revenue cycle at large. That's primarily what we touch on. And as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner. I'm the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask, do you know what it takes to be a certified marketable, let me emphasize that, marketable medical coder? Well, before I introduce my co host, let me share with you information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Hey, it's the start of the birthday week. I got to get it all in every day. All right. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder, well, check the video description for the link. So joining me today is
And
my
where to get jiggy.
yes, that part. Joining me today is my partner in success, my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. Been in healthcare for a long time. Left the bedside in 2014 to start in risk adjustment. Worked in risk adjustment for several years and moved up, and then During the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
All right. And how is that going?
It's coming along. I
It's
had
coming along.
another class that just finished last Wednesday. So,
Okay. Cool, cool.
yep.
I'm glad that we're out here trying to do our part in educating the masses and providing these employers with some wonderful, well qualified, marketable individuals
Yeah,
to choose from.
keyword marketable.
Because, baby, whew, just having conversation with that's a meeting after the meeting. I'll save. Because I be scratching my head like, well, how did you get here? That's all I need to know. How did you get here?
Can I? I asked myself that so many times.
It has become a mantra now. Like, uh-huh. How did you get here?
Clearly, we're not the same. Cause
They not like us.
mm-mm. Dun, 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 dun.
Don't make me go into that line dance. Hey. Oh my goodness. Okay. I'm sorry. We digress. So before we jump in, let me remind you that you can join in and add to the conversation. So don't be shy. Your opinion matters and is always welcomed here. So friends, use the chat. That's how we can communicate with each other, and you can chat amongst yourselves as you see fit. If you have a question, please type Q first so that we know it is a question for us and we don't miss it. So for those who are just joining us or watching the replay, today we are talking CMS 2026 Medicare changes and what coders need to know. When I got this information, I was just like, for real? For real? But okay. But first, let's get into some church announcements. Shall we? Can we kick it? Yes, we can. Yes. Okay. There we go. Hey. Hey.
At the rate things are going on, we really gonna need to channel him.
Absolutely. Ooh, you're right about that. You're right. All right. Let's see. Turn this around. All right. I really don't have many church announcements. The one that I thought was applicable to today's topic is yesterday. I don't know about you. So I subscribe to um, the various Medicare listservs and all of the things. I had never, ever in my life seen so many emails at one time about updates, changes, final rules, proposed rules at one time. They hit like do. I said, well, what is happening? did somebody click the buttons? What happened? They all, I mean, there were like 7 of them back to back to back. I had never seen anything like that before. I said, is everybody okay over there? What? I mean, maybe they got the go ahead. Like, okay, we good. We got our head person in charge, so go ahead and let it rip. And rip it did. I had never seen anything like it before in my entire career. Had I ever seen anything like this before? But that was pretty much mine. I know you have a church announcement. Don't do that. Don't do that. You had to look like, what you talking about? Don't do that.
Oh, are you ready for it?
I'm ready for you.
Okay. my church announcement is I have a new ICD 10 CM class that will be starting Thursday. Actually, this Thursday, April 17th at 6 p.m. Eastern Time. So anybody who is interested, still not too late. You can go to thecodinurse.com for more information and to contact me about registration.
Yes. Yes. I love it. Did you have any other announcement? Because you were looking like, what?
Oh, I do have something I wanted to run by you
Okay.
or let you know if you were interested.
Okay.
Um, I'm part of, ever since I was doing this government contracting thing, I've signed up with this lady who does events for HHS, for CMS, but particularly, well, HHS, but specifically CMS.
Hmm.
So they're having a virtual meeting, I think it was one day next week, it's in the morning, where they're going to be discussing, they're going to have, I think, two attorneys on to talk about the HHS terminations and all this work stop orders and what it means for
Contractors.
contract.
Oh, absolutely.
So
Yeah. Yeah. Yeah.
I'll forward you the email
Oh, yes,
so you can
absolutely.
register.
I'll make some time. Like, wait a minute, let's see. Because I actually, now that you mention it, I'm getting a lot of pings from people. Are you still interested? Are you still looking? And I'm like, what is this? Who are you? And why are you knocking on my door?
Right.
So yeah, that will be interesting. And maybe they just trying to build up their rosters or something. I don't know. I mean, it's I think it's those middleman people that try to put
Mhm.
together. I mean, I'm not like, hey, yes, here's something. No, I'm not doing that. I'm
Right.
not falling for the okie doke. But I just have been seeing more of them lately than I had before. So hmm. Yeah. All right. All right. Well, let me see. Get rid of the banner. Let the tea spilling begin. So again, I'm Clarice Warner, and we're going to talk about some fun things today. The CMS 2026 Medicare changes. Um, and in the title it says what coders need to know, but I think this is applicable not only for coders but all health information professionals and compliance professionals as well, because I feel like there's some work you will need to know or work you will need to do based on the knowledge that you obtain today. At least I felt like there was. Anyway, um, so CMS released, like I said, several of them came last night, but they all have also released the final rule on April 4th, which outlines major policy changes for contract year 2026. This affects Medicare Advantage, Medicare Prescription Drug Benefit Program, which is Part D. Medicare Advantage is MA. So if you hear me say MA, I'm referring to Medicare Advantage. And then the Medicare cost plan and programs of all inclusive care for the elderly. And that is called PACE. So that's not all we're going to talk about. We also have a new CMS administrator, Dr.
Mhm.
Mehmet Oz, who just shared his vision for the agency. So we'll be talking about how his Make America Healthy Again initiative might affect our coding world or health information in general. I'm just loving the visual I'm getting from you. I am just tickled over here. So this is a packed episode. So make sure you get your preferably your tea, but I know everybody's not a tea drinker. Get whatever it is you need to hydrate or keep you caffeinated, because we're about to get into some serious policy changes that will definitely impact your work and probably make you say, huh?
Definitely.
So let's start with the Medicare Advantage changes, which I think are going to have a big impact on how we handle claims processing. So, first up is a major change to inpatient admission decisions. And this one actually is huge. So, CMS is finalizing a provision that restricts plans' ability to reopen and modify previously approved inpatient hospital decisions based on information gathered after the approval. Under this final rule, Medicare Advantage plans will only be able to reopen an approved admission for obvious, quote, obvious error or fraud, end quote. So let's break that down for a minute. So previously, your Medicare Advantage or MA plans could essentially perform retroactive reviews and change inpatient status to observation, even after initial approval. Yes, we've all seen it. But on the compliance side, we've all seen it. Ridiculous. But anyway, um, so this affected, of course, DRG payments and created administrative nightmares for billing departments because then you have to, there's a lot of things that had to occur and be shifted and all kinds of things. Now, if the plan approves an inpatient admission, they must honor that prior authorization. So this is all centered around a lot of the work um, that they're pushing for prior authorization reform. So this should reduce denied claims and prevent those frustrating retrospective downgrades from inpatient to observation status. So I think that could be a good thing. It sounds like a good thing, and it sounds like it's moving in a positive direction to assist with the prior authorization. But there still may be a little something in the water. I don't know. It sounds when things sound too good to be true, usually they are.
Right.
And of course, Mr. Jesse, you know you to jump in whenever, however, wherever you need to. So
Because
the next,
I'm already scratching my head like, wait, because like you said, I used to see it all the time during inpatient CDI. Like somebody had a surgery, and then next, thing you know, I can't find them. The next day or 2 days later because their status has completely changed from inpatient to observation or inpatient to outpatient.
yeah, yeah,
So,
in a blink of an eye, it's like what?
mhm.
Wait a minute, who? But didn't you say you authorized this? So now is different. And that's what made it so frustrating because you're operating based on the authorization. Why did I spend all that time waiting on the people, sending the information, talking to the people to get the prior authorization when you gonna be like, well, you know what? Yeah, we said that yesterday, but today we feeling some kind of way. Really?
But then on the other hand, I can't understand it because some people don't have any complications. Some people are ready to go. Like they have no like their blood work is solid. Like there's no spike in temperature. There's no spike in white blood count. They're going to the bathroom. They're able to ambulate. So I don't know.
Mm, I don't either. The next major change is a closing Medicare Advantage appeals loopholes that have been adversely affecting providers and enrollees. So CMS is clarifying that the definition of, quote, organization determination, end quote, includes MA plan decisions made concurrent to the enrollee's receipt of services. In plain English, that means appeal rules apply to adverse plan decisions, no matter when they're made, whether they're made before, during, or after any services that are being received. They're also codifying that plans must give providers notice of coverage decisions when the provider submits a request on behalf of an enrollee. And perhaps more importantly, they're clarifying that an enrollee's liability to pay for services cannot be determined until an MA organization makes a decision on a contracted provider's claim for payment. This ensures enrollees always have the right to appeal coverage denials that affect their ongoing treatment. The third major change is establishing guardrails for special supplemental benefits for the chronically ill, or SSBCI. For those who may not be familiar, SSBCI are benefits that can be offered non uniformly to qualifying MA enrollees with chronic conditions. This is where they get this is what allows the hopping from one payer to another payer, because this payer 1 month or year may be providing those with chronic conditions that may need to ambulate more and move more, gym shoes. So they will pay for a specialty pair of gym shoes or regular gym shoes or whatever. Whereas this one may be offering a Fitbit. This one may be offered, they offer all these different things for the chronically ill. And folks gonna take advantage wherever they can take advantage. So well, let me jump in here so I can get this. Oh, well, let me jump in here so I can get that. It's crazy. FYI, I digress. But anyway, so these benefits may be non-primarily health related, but must have a reasonable expectation of improving or maintaining the health or overall function of chronically ill enrollees. So the new rule codifies a list of non-allowable examples, including non-healthy food, alcohol, tobacco, and life insurance. So this is going to require better documentation for chronically ill enrollees to justify supplemental benefits and more precise coding to identify which members qualify. So they might stop some of that plan hopping, maybe. I don't know. All right, so let's also mention the risk adjustment data updates. CMS is making a technical change to the definition of hierarchical condition categories to make the reference to international classification of diseases general rather than version specific. So they're changing from specifically referencing ICD-10 to just ICD and substituting terms like disease codes with diagnosis codes and disease groupings with diagnosis groupings to be consistent with ICD terminology. They're also codifying requirements for PACE organizations and cost plans to submit risk adjustment data to CMS, which has been a longstanding practice. So they've been doing this for a while, but it's now just officially added in the regulations. Next, did you have anything? Next, we're going to move on to the prescription drug program updates, which implements several provisions from the Inflation Reduction Act of 2022, or it's also called the IRA. First up is vaccine cost sharing. CMS is codifying that effective for plan years beginning on or after January 1st, 2023, the Medicare Part D deductible does not apply to adult vaccines recommended by the Advisory Committee on Immunization Practices, or ACIP. And there's no cost sharing for these vaccines under Part D. This has actually been in effect since 2023, but CMS is now officially putting it in regulations because the program instruction authority expires at the end of expired at the end of calendar year 20, or will expire, at the end of calendar year 2025. So they're making sure that it's in the guidelines in the event they need to make some changes. Next is insulin cost sharing. Again, effective for plan years beginning on or after January 1st, 2023, the Medicare Part D deductible does not apply to covered insulin products. And the Part D cost sharing amount for a 1-month supply of each covered insulin product must not exceed the applicable cost sharing amount, which for 2026 and beyond will be the lesser of $35, 25% of the maximum fair price established under the Medicare Drug Price Negotiation Program, or 25% of the negotiated price under the standalone MAP prescription drug plan, or the primary drug plan. Prescription drug plan. I'm sorry, not primary. Prescription. They gave me some acronyms. Prescription drug plan, or the Medicare Advantage prescription drug plan. Say that 3 times real fast.
Exactly.
Also, let's talk about the Medicare prescription drug plan payment. So, beginning in 2025, all Medicare prescription drug plans must offer enrollees the option to pay their out of pocket prescription drug costs in monthly payments over the course of the year instead of all at once at the pharmacy. Sir, let me just say this because I have a mother who has Medicare Part D. And at the beginning of the year, we brace ourselves for what this cost is going to be when we drive up to the pharmacy for that first round of medication. It is bananas. It's like medicine that we have been getting for, $50 max, maybe, total for all of the medications becomes because you got your co-insurance, you got all of the things that you have to have going on that needs to be paid, um, deductible, all of the things. So we look at like $500. I'll be like, brace yourself, it's coming at the beginning of the year. And I'm like, at first I didn't realize, and then I was like, this is an annual beginning of the year thing. So don't spend all your money at Christmas because you got to give it to your drugs. It's like, wow. But
And
so
for some people, that really could cause a problem.
it is. So I'm glad that they are allowing this in monthly payments. I mean, you can get everything else in monthly payments nowadays. So why not do this as well?
So you could get your Medicare prescription drug costs on Klarna.
Absolutely. CMS is now finalizing new requirements for an automatic election renewal process that extends a Part D enrollee's participation in the program for the next calendar year, unless the enrollee opts out. I like that too, because they be calling you every year, asking you, well, "What you gonna do? What you gonna do? What you think I'm gonna do?" We sticking and staying. Interestingly, CMS is not finalizing the proposed requirement for Part D sponsors to ensure that pharmacies inform enrollees of the actual out of pocket cost of a prescription at the point of sale. Ooh. Well, I will say my pharmacy, like I do it on my app. And so they'll tell me, so I know going in what it is that I'm looking at when I go get my mom's medication. So whether it's a requirement or not, they do offer it, and I appreciate it because I don't need no kind of surprises when rolling up. Because I usually go through the drive-through window. I don't need no kind of surprises when I roll up at the window
Right.
because I've seen some drama at the window. Folks be like, "What? I ain't paying that." So literally, they arguing with the people through the glass, and then they just get mad and drive off. I mean, this is you be like, "Wow, this is amazing." I know they probably glad. I'm glad y'all at the window and didn't come in the store. Thank you.
Yeah.
Oh, good morning, Miss Vicky. Good morning. CMS noted that this information is already provided to pharmacies through established claims processing, but they are encouraging pharmacies to leverage standard industry transaction data to provide out-of-pocket costs verbally upon request. Yeah, I mean, like I said, they let us know in the app, so I appreciate that. All right, let's see. We also have the prescription drug event or PDE records. This is where things get technical, but really important for billing departments. So CMS is setting firm timeframes for PDE submissions. Initial PDE records must be submitted within 30 calendar days following the date the claim is received by the Part D sponsor or its contracted entities. Adjustments and deletions must be submitted within 90 calendar days following discovery of an issue requiring a change to the PDE. Resolution of rejected PDE records must happen within 90 calendar days following receipt of the rejected record status from CMS. But here's the big one. CMS is establishing a distinct PDE submission requirement for selected drugs under the Medicare Drug Price Negotiation Program. For these particular drugs, the initial PDE records must be submitted within 7 calendar days from the date the Part D sponsor receives the claim. 7 days. That's a significant change from the standard 30 days. And it's going to require some workflow adjustments for many organizations. And then finally, there are new Medicare transaction facilitator requirements. A Part D sponsors network participation agreements with contracting pharmacies must require those pharmacies to be enrolled in the Medicare Drug Price Negotiation Program's Medicare Transaction Facilitator Data Module, which they're abbreviated as MTFDM. Go figure. All right. So this requirement is designed to facilitate continued beneficiary access to selected drugs, promote access to negotiated maximum fair prices, and help ensure accurate Part D claims information and payment. All right. Let's see. So I think those were some of the things. Some of the things that they didn't talk about, because there's a whole list of things that they didn't talk about. But one thing in particular, they didn't uh, add any regulations, and it may be linked to something. People were waiting on whether or not Medicare or CMS will cover the Ozempic, the GL1s. I think
GLP-1.
they were waiting on that. They act like they didn't. They just moved. They just moved aside, blinders on. We're not looking at that. So they didn't add any commentary related to that at all, at least yet. But that was what folks were waiting on.
I don't think they want to touch that because there's no generic equivalent now. Well, for Ozempic, it is up until I think a couple weeks from now because the other one, um, Manjaro, they already you can't compound it. You can only get it directly from Eli Lilly. So if there's not going to be if they don't have to negotiate price, it's kind of hard if there's no generic alternative. So that's probably why they don't want to touch it.
Mm. But another thing that came out has the physician / provider community up in arms. And somewhere I read that the current administration is lightweight pro Medicare Advantage. They got a huge raise. They got money coming in. So those plans are about to get, I want to say like a 5% increase coming in over the year. Whereas the provider community are like, we've been asking for an increase and everybody seems to be ignoring us and not giving it to us. So they not as happy. But somebody made the point that you still benefit. So even though these plans get this additional money, you benefit from either the copay. There's something that they said that they benefit from. And they're like, I guess it doesn't feel the same because of the type, because they're ratcheting their payments down whereas they're giving the Medicare Advantage plans more money. They were not happy about that. That's a whole other conversation. I didn't bring that into today's topic, but I saw that and they were like, mm-mm. The fight still continues. They have multiple battles that they're fighting. And this was one.
They want their compassionate sacrifice recognized.
Absolutely. Absolutely. All right. So now let's discuss the leadership changes at CMS. So I hope I'm saying this. Mehmet, Dr. Mehmet Oz has completed his first week as the 17th administrator of CMS and has shared his agenda and vision for the agency. So for those who don't know, Dr. Oz is a cardiothoracic surgeon and former host of an award-winning TV show. He now leads CMS, which has a $1.7 trillion budget and is tasked with delivering health outcomes for more than 160 million people. Dr. Oz has outlined 4 key areas of focus that align with President Trump's Make America Healthy Again initiative. The first is empowering the American people with personalized solutions to better manage their health and navigate the complex healthcare system. They're planning to implement the president's executive order on transparency to give Americans information about costs. I'm real curious about that because folks, hospital organizations have been bucking that for a minute, and they, in some instances, have provided what was necessary at a bare minimum necessary in order to show transparency. The folks have always said it was never enough, but there wasn't anything mandated. There wasn't anything, to say uh, that if you don't do at least the bare minimum, or that the bare minimum was the threshold. Like they're like, oh, well, they said I gotta tell you some information about a couple of procedures. Let's throw a few of them out here. Some of the common ones we do, whatever. Here's an estimate, and we've met the requirement. And so, but again, there was really no teeth behind it, and so that is going to be interesting to me whether or not some teeth actually becomes a high, because it was supposed to be a way for uh, consumers, us patients, to be able to kind of cost share. You know how we do? Well, let's see what they offered it for. Let's see what they offered it for. Well, let's see what they offered it for. And then you can make informed decisions based not only on, the star rating and the comments from people and what providers are there and what their ratings look like, but also how much is this going to cost me? Because I only got so many dollars. So
Right.
that one's going to be interesting. The second is equipping healthcare providers with better information about their patients and holding them accountable for health outcomes rather than unnecessary paperwork. They specifically mentioned streamlining access to life-saving treatment. Third is identifying and eliminating fraud, waste, and abuse to stop unscrupulous people from stealing from vulnerable patients and taxpayers. And fourth is shifting the paradigm from healthcare from a system focused on sick care to one that fosters prevention, wellness, and chronic disease management.
Mhm. But the question is how, because that all sounds good,
Don't it?
but how?
From a coding perspective, we might see more emphasis on preventive care codes, quality metrics, and potentially new documentation requirements related to outcomes rather than just services rendered. So stay tuned.
I just want to know. I mean, only in the United States can you lose a senatorial race and then end up being the head of CMS.
There's a lot of things only in America you can do. That's why people want to come here, because they be like, it's amazing over there.
Because he just lost last November as to be a senator here in Pennsylvania. The man don't even live here, but I guess he had a house, so technically he qualified. He lives in Connecticut.
Mhm. Buy houses all over the country. You can do whatever it is that you need to do, wherever it is that you need to do it. Only in America. Again, that's why folks are swimming across oceans and being drop shipped from trains and planes and automobiles to get to America. Only in America.
Only. Because I mean, because in all of this talk about health, like you never hear, even with RFK Jr., like nobody's talking about the horrible quality of our food, all the additives in our food. Nobody's talking about that, but they want everybody to be healthy. How?
And then you have food deserts where people who are at the most vulnerable can't even get fresh vegetables that don't have additives or pesticides or any other things. They not only can they not get it, in some cases, when it may be available, it's still not affordable. Um, so you got all of that as well.
Because honestly, I'm surprised that Whole Foods is still open. Because I mean, it came out what last year, I think, late last year, that their quote unquote organic food came from China, and then also found out that um imported food that is stamped organic is not in the level of inspection for those products is less than regular inspection. So how you know that they're really organic if nobody's testing
You
and they
grow it in
charge
your
all that money?
backyard like I do. Okay. You don't. I mean, it's a crapshoot both ways, but I mean, you really and for me, it's really a life altering lifestyle change. Like I'm a label reader. Like, what is this? If I don't know what this is, if I got to pull up my phone to be like, well, what exactly is? I don't want it. I don't want it. It might sound good, it might look good, it might be all of the things. But I try to be so conscious about what I put in and on. Because stuff that you put on your skin, your skin is one of the biggest barriers that's gonna get into your body. Like, um, no, that's a whole other conversation.
Oh, it is. I mean, especially I mean, sunscreen alone for us is an issue because we can't use a physical sunscreen because we'll run around looking like a piece of chalk.
And somebody might grab us and try to write with us.
Exactly. So we have to use a chemical block. But what's in it?
What's in it? What's in it?
So what I do is I just try to use European brand sunblock because they seem to, and all of it really doesn't mean anything because you know what, even American products, they have different ingredients for Europe than they do for us.
They do.
So
That's why people always talk about, and I have never been like, let my children tell them I deprived them of a happy childhood because I never took them to McDonald's. But that's why you have people always talk about it tastes different when you go to different countries. Um, Whatever it is, the same meal, same burger, same fries, same whatever, but it just tastes different. Um, yeah. And then I remember, kids would have who was in my car as a child? I don't know. I think I got some fries or something from McDonald's, and months later, them fries still look like fries in my car. I was like, absolutely not. You will never get another McDonald's fry from me ever in life, and I never took them back. So, but they've eaten them now that they're grown and they can do whatever they want to, but not by me. That was crazy.
I don't know what happened, and there, well, the food quality in the 80s is nowhere near what it is now. But because I really think it was around somewhere in the 80s where McDonald's changed from, well, they're probably genetically modified potatoes. That's probably the start of it. But somewhere in, I think it was the late 80s or very, very early 90s, they switched from frying their French fries in lard. And I mean, who really would have known that that was it? That was their secret sauce because their fries were delicious. Now, I haven't had McDonald's. No.
Yeah, my understanding, people they don't they not they not they're not.
And I hear it's expensive too. Not even reasonable anymore.
I wouldn't know. I wouldn't know. People, I remember when the last time I went to a McDonald's and not to eat because there was nothing that I could eat was when my child used to be on the dance team and they would meet. Like if we were traveling together, they would meet at a common spot and they'd be like, "Oh, meet at the McDonald's." Da da da. I'd be like, what am I getting in there? Nothing. Absolutely. Water. And I don't even know if that water is good, the good spring water. So no, I
How
don't
about
know.
well, look, and I think David, I think McDonald's has Dasani, and that's already been proven to be
That is
just tap
disgusting.
water.
That's
Exactly.
oh God. I am my friends call me a water snob because I'd be like, I don't want that dirt. It
Mm-mm,
tastes like dirt to me. It does
that's
not taste good.
the Dasani is a step above toilet water.
my God. Oh my God. Yeah, she said, it's so sad. Yeah, the food and drug and health system is so corrupt. It's all about the Benjamins in the end of the day, not people's health. You're right, and it's sad.
Amen.
To your point, I think they're working in tandem with each other. Like, we'll give you all of this because we know it's going to affect the health, which means that they're going to be coming to you, and so we pushing you along, just pushing you along through the system.
Exactly. Meanwhile, the powers that be, see that they negotiate, and I heard this a while ago, and it makes sense. Like the powers that be, like see they don't even have like their meat suppliers are not our meat suppliers. Like
Mm,
they contract with ranches that we don't even know about that really are grass fed, and they get their meat products from them, and we don't have access to that.
mm. Wow, interesting.
Mhm.
That's probably why we hearing roosters and hens. I ain't never heard so many, seen so many birds that's supposed to be on a farm in the city in my life.
Oh my God.
Everybody got a pen.
When I lived in New Jersey, my neighbor had a rooster. Literally, the next door neighbor had a. When I'll tell you, I was so glad when I moved. I'm like, I can't take it. I mean, and
Oh,
they only doing
especially
what they
knowing you're
do.
you're not a morning person, so I just
No,
can only imagine.
and they're only doing what they doing. But man,
Be like, just don't do it here.
you have no idea.
Oh,
Oh,
bless your heart. You survived though. You survived. And look
mm,
at you now.
yeah. I mean, then they have one of them little toy dogs. I'm like, dang, even the dog is eating rice and beans. Like, wow.
Like, it's amazing.
I would step out of my door like, where am I? Like, how did this happen?
How did I get here?
Yes,
Oh, that's funny. Oh my goodness. Again, only in America, right?
only, only.
Only in America. All right. So let's see. Some key takeaways um, for us from this information today. Let's see. MA plans can only reopen approved inpatient admissions for obvious errors or fraud. This should reduce retrospective denials and status changes, but might increase upfront scrutiny of inpatient authorization requests.
But we'll see how long that lasts. Yeah,
At
that
least
is
the tea we're
true.
having here is healthy and good. I know my tea is real good. Uh, but you're right. We'll see. Because really,
Cause, I just think that's going to cause some problems in the upcoming month. We'll see.
we'll see. You know, we'll see. Stranger things have happened.
That's so true.
Second, there are new appeals protections for providers and patients during concurrent reviews. So make sure your organization updates its appeal process documentation to reflect these changes. Third, we now have clear guidelines on what's allowed and not allowed for chronically ill supplemental benefits. Documentation for chronic conditions that qualify for SSBCI will be more important than ever. Fourth, there's a streamlined cost sharing for vaccines and insulin with specific caps. This affects how you calculate patient responsibility and how you code these services. Next, there are stricter timelines for PDE submissions, especially that new 7-day requirement for drugs under the Medicare Drug Price Negotiation Program. This will require workflow adjustments for pharmacy billing teams. Um, by 2027, eligible special needs plans will need to implement integrated ID cards and health risk assessments that serve for both Medicare and Medicaid. So start preparing your systems now for these changes. With Dr. Oz's leadership focusing on transparency, provider burden reduction and fraud prevention, we might see new documentation requirements, but also potentially some simplification of existing processes. For dual eligible special needs plans or DSMPs, I just mentioned that about this is being required that by 2027, they have this integrated member identification cards that serve as IDs for both Medicare and Medicaid. They'll also need to conduct integrated health risk assessments for Medicare and Medicaid rather than separate assessments for each program. That's going to be interesting. CMS is also codifying timeframes for all special needs plans to conduct risk assessments and develop individualized care plans with priority given to involving the enrollee or their representative in developing these plans. So, some questions that you might be thinking. How will the inpatient decision restrictions affect DRG downgrades? Well, this should significantly reduce retrospective DRG downgrades. So once an inpatient admission is approved, the MA plan can only reverse that decision for obvious error or fraud, not because they later decided observation would have been more appropriate. Let's see, what documentation will be required for SSBCI exclusions? The rule clarifies what's not allowed, but doesn't specify new documentation requirements. However, it's recommended that clear documentation of how allowed supplements relate to a member's chronic condition and how they're expected to improve or maintain health. And how might the Make America Healthy Again initiative affect claim denials? Well, based on Dr. Oz's statements, we might see more emphasis on preventive care and chronic disease management. So this could mean fewer denials for these services, but potentially more scrutiny of acute care claims that might have been preventable. So to give a little, they take a little.
There you go.
All right. Well, tune in next week as we'll be discussing another hot healthcare information topic. And as always, you won't want to miss it, right?
No, I think for the next 4 years, it's going to be tea everywhere because with this motley crew,
you never know what you're gonna get.
it's going to be interesting. It's going to be for some good. They'll supply some good reading.
Absolutely, and some chuckles too.
Because we know. It's obvious that the whole system needs to be overhauled, but I just don't know if if these are the shepherds that are going to get us there. We don't know.
And I feel like it's like knee jerk. Okay, well this is a lot. Out with it.
Yeah.
But you don't even consider. It's just like when people leave an organization and folks don't really understand or appreciate all of the things that some person may potentially did to help the process. And so then when folks are waiting, like, well, we've been waiting for so and so to give us, well, so and so gone, and they've been gone for a week or two. Well, we got all of this stuff that we want, and it creates chaos. So again, making sure that folks understand what all the spokes in the wheel supposed to do before you flip it on its head is very, very important.
He was on third.
Right. All right. It's gonna be wild. A wild ride. Stay tuned. We got a wild ride coming.
Mm-hmm.
So are you thirsty for fresh perspectives on the healthcare revenue cycle? Well, by becoming one of the PRNT sippers, you'll join a community of sharp minds who savor the complexity of the healthcare revenue cycle. So why sip alone when you can steep in knowledge together? Come, let's spill the tea on industry insights. And here's what you can expect as a valued member of the Tea Sippers. Exclusive healthcare insights. So gain access to in-depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. early access, be the first to receive expert insights and guides, ensuring you stay ahead in the ever evolving healthcare industry. Personalized support. Enjoy direct access to our team of experts for guidance in medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And my favorite, community connection. Join a private community of healthcare professionals where you can network, share experiences, and collaborate on finding solutions to common challenges. So, by supporting us, you're not only advancing your healthcare knowledge and career, but also contributing to the success of the Professional Reimbursement Network, LLC, a resource that empowers healthcare professionals like you to thrive in their roles, goals, and dreams. So thank you in advance for considering becoming a member of the Tea Seppers. Now, I said this and I say this. For the cost of 2 cups of tea, you can a month, you can join the community. I went to Starbucks over the weekend. I'm talking about regular tea. I ain't talking about Starbucks tea. I said, oh, is this what they pay at the place for tea here? So for regular tea, 2 cups of regular tea, you can join the community. Check out the link in the description of the video. Or you can go to bit.ly/ the PRN Zippers for more information. Again, your support means the world to us, and we look forward to helping you excel in the world of health information and healthcare revenue cycle. Yay. So again, thank you all for joining the Saturday morning tea or checking out the replay. Was the tea spilled today? Yes, yes.
We have a comment from you. You're welcome, Vicky.
You're welcome. You're welcome. You know, I'm so bad about the other side. Were you able to do your you still
No, because well, my StreamYard, I'm only able to pick one. I can only go.
oh, one or the other. Okay. Okay. Well, I see Glam Babies 88 joined us over on the other side. And I never know what's going on unless the people comment on LinkedIn. I never know. Even though their comments come through, but I don't know who joined, who's watching from there. I don't get that kind of that intel. All right, all right. So before we sign off, of course, as always, I have a special request for you wonderful, amazing viewers out there. If you found this information and episode helpful, don't keep it to yourself. Share the knowledge with your colleagues by hitting the share button. And hey, why not subscribe to our channel while you're at it? That way, you'll never miss a drop of our health information, compliance, revenue cycle, and medical coding tea. And if you have thoughts or questions or experiences that you want to share about today's topic or really any topic, we'd love to hear from you. So drop a comment below and let's keep this conversation brewing. And if you enjoyed this episode, of course, give us a thumbs up. It helps more healthcare professionals find our content. And also check out the Coding Nurse channel on YouTube and what you got over there? The Coding Nurse on Instagram. Yes. Okay. Remember, at the Saturday morning tea, we're all about building a community of savvy, informed healthcare professionals. So people won't look at you like, how did you get here? So like, share, subscribe, and comment, and let's grow this community together. Mr. Jesse, do you have any closing thoughts today?
I just wanted to say, did you notice that Ahima, I don't know where I was on LinkedIn, I might have been. They got a whole full-fledged commercial advertising their
The conference.
yeah, in October. Look at them starting early. And it was
They do that every year, but they don't be this early.
I was going to say, I don't remember. Yeah.
They don't do it this
It was
early.
nice. I'm like, look at them.
You coming?
Getting the word out. I might.
Come on the first day. I'll be there at least. Well, I'll be there for the House of Delegates anyway.
Okay.
If not the whole.
We'll see. I did because I'm seriously considering it because I even looked at flights. I don't like connections, so that I can get a direct flight from from Philly to Minneapolis. So
okay,
I really might.
Well, let it know. We'll be doing the tea out there.
Yeah, and I was like already because I don't even know. I didn't know if they had like you know how they all have like a signature or like a guest hotel. So I
They
was just
do. Usually they do.
so
They
I
do.
was just looking to see which one was closest to the convention center. And there's
Usually, is it open for conference now?
well, I don't know because because according to the ad, it said that it, register because registration is not even open yet. It's
So when
gonna.
you go through the registration,
Mhm.
when you go to their link in registration, there's a separate place for the hotel, and then they give you options for the various hotels that they have blocks at or for or whatever. Um, yeah, so that may be. But I'm like you. Well, if you show in the commercial, why wouldn't you have your stuff ready? People may be ready to go.
But I had already done my research. I mean, I had already looked around to see what hotel the closest hotel,
Hmm.
and then they even had the floor plan
Oh, for the
for the exhibition, like for the booths. I mean,
okay.
I'm like, all right, man.
Right, right. All right. Well, Hema, you know what? I've never been to an AAPC national convention ever.
No.
I've never been.
And I think last year they were in Las Vegas. I'm not. I'm sorry.
I've
I'm
never
Las
been.
Vegas. I don't know where they are this year.
I don't either. I don't. I never really. It was never. Well, because for years and most years, I can get all my credentials or my CUs from attending the HCCA, and they're in Vegas this year. But I'm not going.
Oh,
I'm trying to debate whether I want to jump on the virtual one, but I don't know. She
with
said you have
AA
a virtual option.
with AAPC, like even when I was getting the monthly magazine, like I don't know, they just didn't seem. It just didn't. It just seemed like a knitting convention. It just didn't seem like it'd be interesting.
Did you say a knitting convention? I cannot. Actually, I went to a sewing convention before. It was fun.
I mean, because even like I
But
mean,
it's
'cause-
for that community. Like you
right.
and to me, I've always had more excitement or buzz around their local stuff. Like their local events have to me were worth the time and money spent.
Yeah, they might need to copy what what AHIMA's doing because they had, I mean, they had a little hype to it, like the fast frames, to, kick up some excitement. And I saw Dr. Jasmine in the clip. I'm like,
She
all
was
right.
everywhere.
hmm I mean, I was impressed. 'Cause, look, we always, I give AHIMA the business a lot of times, but I mean, I give credit where credit is due.
Yeah. Yeah, because they have and dude is cool. The photographer guy. Well, they have a team, I think, of photographers around actually that is capturing all of the different things. But and then they pull it all together. The only thing is, I don't know. No, it wasn't there. It was at the other place. They offer these headshots. That's usually one of the places that you can get free headshots at these national conventions. And my thing is, the guy that I have had, the one that they use for AHIMA within the last couple years have been the bomb. He is excellent. Sometimes though, you be like hit and miss with folks. Like, where did you find this person? And the end product. Why you ain't edit the end product? They paid you. Do something. Make it better. I could have did that. Everybody got iPhones. We could have did that. So
Right.
do something. Do better. Be better. But like I said, the guy that they have now, he's really really good. Um, and the photos that I've seen of people when you go and because you can. they just give you a link and you go in and pick your photos. And you can take as many as you want, really. You know, you're not limited to just one. You can go and have your outfit change and then pick the ones. That's what I do. You can pick the ones that you want to use. But just, you know, if you're offering those free headshots for folks, make sure you got somebody that's going to at least do the work that you pay them.
Right. Because they are important.
They are important. That's one way to be marketable. Put your headshot out there. You never know when you're going to need it. And that's what you should be. Well, that's a whole other conversation. For your LinkedIn and your, yeah. Okay.
All right.
This has been a great session today.
Yeah.
See, we done dipped into the meeting after the meeting before we done. This has been a great session. So CUT Sippers at 10:15 Eastern Standard Time. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend.
Bye-bye.
Bye-bye.